Yeah, so feel free to make notes, but obviously you'll get a copy of the recording, which hopefully you'll be able to listen back to and will be helpful. I'm just going to screen share as well. Okay. Let me just set this up to allow anyone back into the room. We start. Okay, don't worry, Corinne, it's fine. Yeah, you'll get the recording. I'm just trying to work out how to open up. I'll just have to keep checking back for anyone joining. Fab. Okay, let's get started. So, okay. If you can't see that for any reason, can someone just let me know in the chat? I'm hoping you can. It says I'm screen sharing. Sorry, I'm just trying to get the Zoom so that I can see more while I'm screen sharing, but I'm not sure I can. Okay, chats. Perfect. Oh, thanks, Kate. Okay, fab. Hide non-video, make host. Okay. I'm just going to do one last check to make sure no one's in the waiting room, but I'm not sure how to do it from this screen, which was, oh, here you go. I'm getting, oh, we're good. So I just need to keep an eye out for notifications. Okay, fab. Right, let's get started. Okay, so like I said, we're recording, so feel free to make any notes, but you will get a copy of the recording emailed out to you in advance. And yeah, if you've got any questions, pop them in the chat. I will try and answer them as I go through. You might find that I naturally answer the question. If I feel like I've not answered the question, I'll go back to the chat, and it might be that I've seen it, but it slots in at a more convenient point to talk about whichever topic you're asking about. So just because I don't answer it straight away, please don't feel like I've missed it. Give me 1 second. Sorry, I'm just trying to move this to the side. As you can see, my technical skills are exquisite. Hopefully you'll still be able to see the slides. Okay, so I'm going to just introduce myself a little bit first. So my name is Rachel, so I'm an acupuncturist, and I have a diploma in reproductive medicine as well as my degree in acupuncture. And I'm really passionate about fertility awareness. So I actually had my son after 3 IVF cycles. So the 3rd cycle was the successful one. And that was after, you know, an experience that I always look back on as being a positive one, because obviously it had a successful outcome, but there were lots of things throughout that journey that if I could have done differently, or if I felt like I'd known more, might have changed perhaps the number of cycles that I'd needed to have, or the way I went about it, or just, you know, certain parts of the experience. So I was finally diagnosed just before that 3rd cycle with something called Hashimoto's disease, which is autoimmune thyroid disease, and then something called natural killer cells, which we'll touch on as well. It's basically just an autoimmune response. Prior to what I do now, I was cabin crew, but once I'd had my son, I decided I wanted to retrain and just basically help women going through similar. I'm really passionate about educating people about fertility. I feel like there's so much you can do to optimize your chance of success, and I believe that knowledge is power, and that there's a massive gap in the world of fertility. I feel like people jump straight from you know, struggling to conceive to IVF with not much in the middle, so I try and kind of fill that gap a little bit. And areas that I kind of like to specialize in are endometriosis, reproductive immunology, and then getting to the root cause of things really, so helping people work out why they're struggling to conceive, which essentially is kind of what this session is all about. So yeah, that's me. So I want to start off just by talking about what unexplained infertility actually means, because I think it's a term that's bandied around a lot. It's definitely overdiagnosed. So quite often, being told that you have unexplained infertility simply means that not enough investigative work has been done. There's not been enough time spent to look into the diagnostics about what might be going on. And that can be for a number of reasons. So certainly with the NHS, resources are limited. And rather than an NHS consultant perhaps saying to you, look, this is as far as our remit goes, we are unable to help you any further. Quite often they might just say, well, you know, that's not an option, or we can't do that, rather than saying to you, but you can go elsewhere for that. So you're kind of left feeling that that's the end of the road and there's nowhere else to go. In fact, there is, you just need to look elsewhere for it. And that's a communication issue, you know, and I think these things are changing slowly, but that can be a big barrier. I also find with people, it's not just limited to NHS. I also find patients that are having private treatment, sometimes it's communication. So the consultant might think they know what the issue is, but they haven't communicated that with you. So you're left feeling like it's unexplained. But it is that they've got maybe a rough idea, or they know which route they're going down, but it's just not been communicated to you, and you're left feeling, yeah, like it's unexplained. I think IVF is often seen as the answer. Nowadays, you tend to walk through the door of a fertility clinic and you are sold IVF. I think it's probably fair to say that a large majority of IVF and fertility clinics are run as businesses, and they're not always patient-centred or patient-led care. That's not the case for all clinics by far. There are some excellent clinics out there, but it's definitely an issue within clinics that, you know, I think not enough time is spent looking at the reasons why you might not be able to conceive naturally, and other options before IVF. Fair enough, some people might want to go straight to IVF. I completely understand that. And in certain scenarios, which we'll come to, that might be the best option. But I think, yeah, there's this gap between, you know, actually other things you can try. And there's sadly a degree of gaslighting as well. You know, education-wise, as women, we're often told painful periods are normal, you know, take some paracetamol, go away and stop moaning. That is not right. And I think as women, we're educated from a young age on how not to get pregnant. And we're educated, you know, that painful, irregular menstrual cycles are just something we need to put up with. And, you know, it's really not the case. And yeah, what if you don't want IVF? IVF actually was designed for couples where the sperm quality was so poor that in vitro fertilization was the only option, or for women that have no fallopian tubes, so therefore the sperm are unable to get to the egg naturally. They're the two sort of key groups that IVF was designed for. Nowadays, it's come on leaps and bounds. The success rate, you know, it's between 19 to 32%, depending on your age. And that has improved a lot, believe it or not, over time. But ultimately, if you go into IVF not knowing why you can't conceive naturally, then it can sometimes be a little bit of a stab in the dark approach. I think if you go in knowing why you need IVF, or knowing why you're there, or why you can't conceive naturally, you can do so many things to optimize your chance of success. You really can. So I think that's really important that you go into it knowing what's going on. And yeah, I think, I'm not sure if you can see that little bit at the bottom. Let me just see if I can move this 1 second. I'll keep it like that for a second. So yeah, just sort of, clinics are run as businesses, so I think we need to bear that in mind. Not all clinics are, you know, money grabbing, but I think, yeah, it's definitely worth bearing in mind when you're given information, what the intention might be behind that, or why someone might be encouraging you to go straight to IVF. It's good to question things, and we'll come to that at the end. We're going to talk about some really practical advice and guidance about how to talk to medical professionals and how to get the best from consultants when you don't really know yourself what's going on. So this is a really interesting slide. Just give me 1 second. Let's play. Okay, so I'm really sorry. This is my really poor technical ability. I want to try and move this out of the way. I'm going to close the chat just for now, just so you can really see this slide. And I'll do that. Okay. Okay, so this might seem really basic, but I think when we're trying to work out why you can't conceive, this picture is really helpful to take it back to basics. I'm going to talk you through it and you'll see just how many steps are kind of involved. So understanding why you're struggling to conceive is a case of working out like what your fertility pinch point is. And it's really important to mention that what stops one person from conceiving might also be the same reason that another person's IVF is unsuccessful and another person suffers a miscarriage. We can't talk about fertility without talking about miscarriage and unsuccessful IVF within that, because all the reasons are the same. It's just a case of at which point of the process it's happening for someone. So first of all, your egg needs to be recruited and developed, and that starts 3 months before conception or before ovulation. So this is all about egg quality and all about hormones. So your hormone balance will affect the quality of the eggs in that 3 months before you actually ovulate or before you have egg collection in an IVF cycle. So the 3 months before is really key. And if your hormones at that point are not doing what they should do, then it will affect your egg quality to some degree. There's a big age factor related to egg quality and other health factors involved. But by making sure your hormones are balanced, that you can really have a big impact on the egg quality. Once the egg is ovulated, or you could say collected in an IVF cycle, but that's not really relevant to what I'm going to say now. But you see in this picture, you'll see this second picture here, the second circle, you'll see the egg's just being ovulated. Now it has to get down the tube. So first of all, is that tube clear? And then secondly, are you actually ovulating? So believe it or not, something I see in the clinic a lot is women who are having a regular menstrual cycle, but it's not really a cycle because they're not ovulating, and a couple of well-timed blood tests and a few scans, and we can work out that actually not ovulating properly. So it's perfectly feasible to be having a regular menstrual cycle and not ovulating. And quite often this happens if your periods are really light, often not a normal menstrual cycle. So if you have really light periods, definitely worth investigating a little bit further. And also women who are polycystic sometimes struggle to ovulate properly as well. So once you've ovulated, the egg has to get down the tube. And then you'll see in that third circle there, the sperm enters through the cervix. So in terms of this process, it's all about male factor, isn't it? So is that sperm able to swim properly? Is there enough of it? Is it the right shape to fertilize the egg? There's a lot when we're thinking about sperm. Is there any cellular damage to the sperm that's going to stop fertilization? So once that sperm gets through the cervix, it then has to get to the egg, which is normally still in the fallopian tube. So again, lots of areas where things need to match up or things need to be happening at the right time. Is the sperm, if the sperm's getting to the egg, is it actually fertilizing the egg? We talk a lot about sperm morphology, which is the shape of the sperm head. And that has to do with how it fertilizes the egg. So if there's an issue with morphology, sometimes it means that the sperm struggles to fertilize the egg, basically. And then if fertilization happens, we need to be thinking, I need to just move this again. We need to be thinking about implantation. So this is really when we're really concentrating on uterus environment and uterus lining. So there's a couple of key things here. So is the uterus lining conducive to implantation? So there's no scar tissue, there's no fibroids, there's no polyps, there's no structural abnormalities. And we're going to talk all about this in more detail. Is the progesterone level sufficient that it's supporting the lining and supporting implantation? There's a lot from a physical structural point of view that the uterus needs to have right in order for implantation to happen. And then if implantation starts to happen, does that embryo continue to develop normally? I'm looking at this sixth circle now. Is there healthy blood flow to the uterus? That means the embryo continues that implantation process and develops normally. Is your body reacting properly to the embryo and recognizing it as a baby and that it wants to keep that baby and it's not having this immune response towards the baby and causing a miscarriage? So there is a lot to be thinking about when we look at these steps. Like, to say that someone's fertility is unexplained, have we looked at all of these things? Like, there's a lot involved in the process when you really break it down. And that's why I wanted to show you this slide, because you'll quite often find that this, certainly if you're having NHS support, this section here is ticked off. So they will do a hycosi to check that your tubes are clear. And they will probably check whether you're ovulating. They will do a very basic check of your hormones, and they might do a very basic sperm sample test. I feel like this second part is where the system fails a little bit. There's often not enough investigation done into uterus issues or abnormalities. Certainly, immunology and recurrent miscarriage is a failing area, I would consider, of the NHS. So, yeah, I mean, even in this beginning part, the checks that are done are very basic, and sometimes they're not even done, I hate to say. I have definitely seen scenarios where it's not done. I'm just going to go to the chat and see what the question is and see if we can answer that now. Kate, I've been prescribed progesterone privately, Dr. Dimitri, for 3 months to see if it helps with spotting. Could the progesterone I take help with egg quality? Okay, so progesterone we're going to talk about a little bit, but this is a really good question. So if you have spotting before your period, quite often this means that you have low progesterone. It's definitely a question that I ask every single one of my clients, because it tells us a lot. So yes, if you have spotting, progesterone can definitely help. If progesterone is the only issue, then yes, it will massively increase your chance of success. If there are other issues going on that haven't been investigated, or you haven't even got to that point yet, I know Dr. Dimitri, and I know that he will prescribe that first. And then perhaps maybe if you're not having a successful, healthy pregnancy after 3 months, that's when he will start looking further. But it's definitely a really good starting point. Obviously, depends how long you've been trying. Progesterone egg quality. Progesterone is happens in the second part of your cycle. So progesterone comes from ovulation. And quite often, if we don't have, if we're not ovulating or we don't have what we call a healthy ovulation, progesterone levels can be a little bit lower. It's really common. So the progesterone in that second part of the cycle will certainly have an impact on your hormones in the first part of the next cycle. So you might find, Kate, that if you don't conceive on one of these cycles, that your period is maybe a little bit heavier after you stop the progesterone, because it affects the uterus lining, and that then has a knock-on effect on the hormones for the next month. Can it help egg quality? I wouldn't say progesterone is so much egg quality, it's more lining. It will help hormone balance overall. But yeah, it's not so much egg quality. There's lots of other things you can do to help egg quality, such as taking the right supplements and looking after yourself in that 3 months before conception. But yeah, progesterone will definitely help if that is an issue. And like, you've got the spotting, so yeah, that would be like the classic scenario we would want to prescribe that in. Okay, I'm just going to close that down again. Okay, so hopefully that picture helps. So I'm going to move on. I'm actually going to keep the slides like this. Hopefully you can all still see them, but I can use the mouse to point to things, so it's a bit easier. So common causes behind unexplained infertility. So I'm going to go a little bit more into detail into the different areas of that diagram that we've just looked at. So undiagnosed conditions. This is something we see all the time in the clinic, most commonly endometriosis, adenomyosis, and polycystic ovary syndrome. Believe it or not, I have had many a patient that have had repeated unsuccessful IVF treatments, and then gone on to be diagnosed with either endo, adeno, or polycystic ovaries, and then had a successful, healthy pregnancy, whether that's naturally or whether that's through IVF, but getting the diagnosis has been a key difference to the success. So endo often presents with symptoms that we're told are normal. So it goes back to that poor education as well. So if you have heavy flooding periods, if you have pain, if you have clotting, and also sometimes the spotting before the period, you can have pain on having sex. You can have pain when you empty your bowels, sometimes painful ovulation. If you look up like the Endometriosis Society website, there is a massive list of symptoms, all the way down to things like bladder irritation, feeling like you've got cystitis. So, and it varies massively for everyone. It can also present completely silently. So for a lot of women, the first sign is infertility, and then they go on to be diagnosed. It can affect egg quality because of the hormone imbalance behind it. It can affect fertilization. mainly, I think, because of depending on where it is, if you have it on your ovaries or if you have scar tissue within the uterus, it can affect the ability of the sperm to get to the egg. It can affect your tubal health, so your fallopian tubes, the uterus environment, because again, it can affect the uterus lining, and progesterone levels for sure. Adenomyosis is something very similar. It presents again with similar menstrual symptoms. It used to be something that wasn't often diagnosed, but advances in sonography now are making us sort of more able to diagnose it. It basically is similar to endometriosis, where but it's slightly different in that you have tissue that grows into the muscular wall of the uterus. I'm not going to go into too much detail about it, but feel free to drop me an email or something afterwards if you've got more questions. But it basically affects fertilization, the tube health, uterus, progesterone, but really importantly, it has an increased risk of miscarriage because that lining is often compromised. And both endo and adeno, there's a big scale. So you could sit anywhere within that scale. So you could have very mild case or very severe case. And that happens, you know, over time, a long time. It's not something that happens quickly, but it does vary a lot from client to client. So it's really important about having the right diagnostics done, and then sometimes getting a second opinion as well. Just going to mute you, whoever that is. Can you just mute whoever that is? Just muting yourself. Thank you. If you've got a question, if you want to talk, just pop it in the chat. Yeah, so that scale varies a lot. So it's about getting a diagnosis and sort of digging a bit deeper to find out sort of you know, how it's affecting your fertility, because it's one thing having the diagnosis. I have lots of patients that are diagnosed with adenomyosis, but actually when we look at the uterus lining in more depth, it's not affecting their fertility. It might be giving them menstrual symptoms, but it might not always affect your fertility. So it's really important to look at where you sit on that scale. And then polycystic ovary syndrome can be massively undiagnosed, often presents with high levels of what we call androgens, which are male hormones. So you might have a little bit of a heavy tummy or more hair on your arms or some peach fuzz hair. You might have bad skin. It's not always the case because you can get 4 different types, but that's the typical most common type. Affects egg quality, but the good news is that you might be fertile for longer. Just realised my typo there, sorry, longer in life, because you have generally a higher AMH, you have more ovarian reserve, so you're polycystic on your ovaries, so you've got lots of follicles on your ovaries, so you've got more follicles later in life, and your AMH is generally higher, but generally it has an effect on egg quality, and it definitely causes issues with the uterus lining thickening up. So if you struggle in an IVF cycle to get your lining to the thickness it needs to be, it would definitely get checked for polycystic ovary syndrome, for sure. Another common cause we're going to move on to. So this is like conditions, and then we're going to move on to uterus abnormalities. So fibroids and polyps. So if they're impacting within the uterus, I'm just going to point here at this picture. So if they are protruding, can you see where my mouse is? Protruding into the uterus or affecting this cavity in any way, they should be removed. You can get fibroids here on the outside of the uterus, or ones which sort of project into the uterus. They're not so vital to be removed, but anything that's protruding into the uterus and therefore coming from the uterus lining should be removed. A really common symptom of polyps is spotting at any point throughout the cycle as well. And the reason they should be removed is because it could affect the implantation or the ability of the embryo to develop. Now, if you're under NHS treatment, they will often do a hysteroscopy, which is a camera that goes through the cervix, and have a look for these sorts of things. They don't always, though. So if you are about to undergo IVF for unexplained infertility and you've not had a hysteroscopy, I would be requesting one just to make sure that there's nothing going on within the uterus lining. You can also have scar tissue and adhesions. So these can come from numerous things, and this is actually much more common than you think. So it can come from surgical management of miscarriage. Sadly, it's often something that's not really, it's common, but it's not made out to be as common as it is. Adenomyosis can cause scar tissue as well, and any surgery that you've had to the uterus, so a laparoscopy or also a C-section. If you're struggling with secondary infertility and you've had a C-section, sometimes scar tissue can cause an issue within the uterus lining. So if you have scar tissue or adhesions, it often presents with no periods or very light periods. And that is often because the scar tissue stops the uterus lining from discharging properly. Sometimes it can be painful as well. But it does need to be removed and treated. So any sign of any scar tissue or adhesions, it needs to come out. And nowadays, they have quite an advanced technique where they, a gynecologist would go in, take out the scar tissue, and then they would put like a hyaluronic gel on the inside of the uterus that stops the scar tissue reforming. And then quite often you're able to try and conceive again fairly quickly. Quite often tends to be diagnosed in women that have miscarried, because sometimes there's a little bit more sort of uterus investigation, for want of a better phrase. And then the uterus shape, this matters because lots of implantations happen here in the upper third of the uterus. And if you have what we call like an arcuate uterus, which is where you have a slight deviation here, so you have a slight bump, the uterus is a slightly different shape. Hopefully you can all see where my mouse is there. That sort of tissue, so I'm going to sort of explain my hand. So when the uterus develops, it starts like this, and then this middle bit of the uterus should sort of flatten out to form the uterus shape. Now, sometimes that doesn't happen and the uterus ends up like this a little bit, so it's called an arcuate uterus. In severe cases, you get a bicornate uterus, where you have a much bigger sort of, or septate, where you have a big bit of tissue that sits in the middle of the uterus, sometimes creating two separate spaces. This is quite complex, and you don't always operate on a bicornate uterus, but certainly if you have like an arcuate uterus where you've just got like this little bit at the top, you want it removing. And that is because, first of all, that's where most implantations happen. But secondly, when you have this scar, it's almost like a fibrous tissue. There's not enough blood supply to it. So it's a bit tough. It's not like proper uterus lining. And therefore, if implantation happens around there, there's no blood supply. So that quite often needs to be removed. Uterus abnormalities do come with a high risk of breech birth, miscarriage, and preterm labour. Quite commonly, if you have endo, sometimes there's uterus abnormalities. When I'm talking about removing this arcuate uterus here, there's a lot of debate around sort of like the depth of that. Like, it's measured in millimeters, so that's, you know, I'm talking about very small levels, but some will say less than 10 mil you should leave, others will say always remove it. So if in doubt, get a second opinion about that for sure. I think if you're suffering with repeat miscarriage or repeated unsuccessful IVF, then it is worth getting it removed, just for the sake of kind of like it's ticked that box sort of thing. And then any lining issues. So the lining's really sensitive. So any infection or inflammation, so that can often come from pelvic inflammatory disease or something called a hydrosalpinx, which is where you get fluid that sits in the tube, which can be really common with endometriosis. This tube is inflamed, has fluid in it. That fluid seeps down into the uterus, and you get like this infection markers. Can be silent, where you just have this inflammation within the uterus. Again, all of these things can be checked on a hysteroscopy, which is a camera that goes into your uterus, or not even, a hysteroscopy is almost a little bit of an sort of outdated way now. We still use it a lot, but we also use something called saline sonography, which is where they pop a little bit of saline solution into the uterus and they inflate it basically, and they can have a look for all of these things and have with a camera have a really good look. I think they put the saline in and then they either do a transvaginal ultrasound or an abdominal ultrasound, and they can see everything. So it doesn't even have to be a surgical investigation nowadays. You can have saline sonography for sure. And then we have male factor. So going back to our sort of fertility pinch points, we talked of that third circle was all about the male side of things. So is the sperm swimming? If your motility is lower than 40%, then the swimming capability is not great, and that will definitely affect natural fertility. The morphology, I talked about the shape of the sperm, being able to fertilize the egg. So it's considered that lower than 4% morphology is poor, but I have definitely had patients in the clinic where the morphology's been around 1 or 2 and they've managed to conceive naturally. So it doesn't mean that you can't conceive naturally, but it does mean that you want to do everything you can to improve it, to improve your chances. So, you know, we talk a lot about, certainly in the clinic, about with unexplained infertility, it would be great if there was one issue and then you find out what that issue is and you treat that one issue. And what we often see more often than not is that it's a combination of factors that need optimizing. So if your partner has 4% or lower morphology, then it might be that, yes, there's some other things going on, but by improving the morphology, then you're helping your overall chance of success, whether that's naturally or through IVF. So generally, when the morphology is poor, if you're having IVF, they'll do ICSI instead, which is where they fertilize the egg instead of leaving it to do its thing. Poor sperm count. So it's really as simple as there's just less sperm, so there's less chance of getting pregnant. Below 15 million is considered like low. And then high DNA fragmentation. So this is like damage to the sperm at a cellular level. It's got big links to recurrent miscarriage. I wouldn't necessarily jump straight in with a DNA fragmentation test, but if there are some parameters that are showing, like these normal parameters that are showing on a basic sperm test that are not quite right, or you've been trying for like 3 years with no positive pregnancy test, or you've had recurrent miscarriage, then I would be looking at a sperm DNA fragmentation. Again, when we're thinking about fertility, we have to look at your individual circumstances. You know, if you've only been trying for 6 months, would I recommend that you go and get all these tests that you can spend all this money on? No. But if you're much further down the line and we've eliminated the basic causes, yeah, we need to start digging a little bit deeper. And generally, if there's some parameters of a sperm test that on a basic sperm test are looking like they're not quite optimal, it's worth investing in that scenario in a DNA fragmentation. And any of these issues with sperm can be caused by numerous factors. I found this on the web. Oh, watch is talking to me. Can be caused by infection. So low-level underlying infection is really common in men with no symptoms. Sometimes it can be passed from male to female as well. So I talk a lot about the vaginal microbiome and things like thrush and cystitis. It's the same with bacteria. We can pass them to and from each other. And sometimes you can be have no symptoms, asymptomatic. So a simple semen culture will check that. A varicocele, which is a varicose vein in the testicle, really, really common, and a bit like endometriosis in women, it's often undiagnosed, sometimes presents with no symptoms, and also hormone imbalance, the same as it happens in women, and lifestyle as well. So if you have a concern about the male factor side of things, or you've had some parameters that have come up abnormal rather, then I would recommend further investigation in that area and find yourself a good urologist. So again, I'm going to come back at the end and talk about where you can look for these sorts of things. But a good urologist will check for varicocele infection, hormone imbalance. They'll know exactly what they're looking for. You won't get that degree of care on the NHS. They will do a basic sperm sample. So they will look at these top 3 things and a few other bits and bobs. They won't do the DNA fragmentation. And unless there is like a history of anything, or your partner is presenting with symptoms such as like testicular pain, you won't get these investigations. It's really sad actually with the NHS. Quite often they won't investigate something for fertility purposes, but if you go and say you've got pain or it's affecting your lifestyle in some way, shape or form, which we all know infertility does, but they won't look at that. They'll look at it how it's affecting other areas. So, for example, if you go and say you've got really painful periods and you push and push and push, they might do a laparoscopy and look for endometriosis, but they won't be looking for it for a fertility case. It's like their disconnect is going on. So again, it comes back, this unexplained kind of term comes back to, is it really unexplained, or is it just that those tests aren't available in whatever clinic you're at, whatever care you're under, or that they've not been offered to you and you don't know they're there? Because let's face it, why would you, unless you've spent a lot of time on Instagram or Google. So yeah, that is kind of the male side of things, but we'll definitely talk about urologists at the end. And then these are some other really common causes. I'm not going to go into loads of detail about these, but we will touch on each of them. So thyroid function, so a thyroid antibody test and a full thyroid panel. If you've, again, looking at things in the bigger context, if you've been struggling for a long time, or you've had recurrent miscarriage, because thyroid is intrinsic with miscarriage, has your thyroid been investigated fully? On the NHS, they will probably only check thyroid antibodies as part of a recurrent miscarriage panel, i.e. if you've had 3 or more miscarriages. If you've just had unsuccessful IVF, they're not going to look at your thyroid antibodies, and they're certainly not going to be looking at it for unexplained infertility in a natural circumstance. Like before you went for IVF, they wouldn't be looking at thyroid antibodies. But thyroid function is key for fertility, something that's massively sort of undiagnosed or not looked at in enough depth. And it has big links to lots of things. So you can use Medichecks to get your thyroid checked, finger prick testing service. Again, I'm going to come and talk about all these places you can go to get these checks done. There was a tablet trial done. It's quite a big trial that showed that thyroid antibodies didn't affect fertility, but there's also been lots of studies done to show that it does. So it's kind of one of those things, it's a bit of a grey area. Vaginal microbiome. Loads of chat about this recently because Tommy's recently did a big study that linked low levels of lactobacillus, which is good bacteria that we want there, to higher risk of first trimester miscarriage. So if you've not got enough good bacteria in your vagina, you've got a high risk of first trimester miscarriage. And how I talked at the beginning about how what is the cause for one person can also be the cause for another person at a different point. If your vaginal microbiome is imbalanced, and we know there's a link to first trimester miscarriage, there's a high chance that could stop you getting pregnant as well in the first place, because it all links. Vaginal microbiome issues can present with no symptoms, or it could be signs of things like recurrent thrush, recurrent cystitis, BV, aerobic vaginitis, anything vaginal that's not quite right. Get your vaginal microbiome tested. That is not available on the NHS. That is a private test only. The NHS will swab to look for, it's called a high vaginal swab, to look for a few bacteria, but they certainly won't be looking at the lactobacillus, which is the good bacteria. And you can, this is what, if anyone's taking Canis flor, anything like that, Canis flor is lactobacillus. So if you've got any worries about vaginal microbiome and you don't want to pay for the test, at the very least, take Canis flor. I would probably recommend, and a lot of clinics now for people who are going into IVF are now recommending that they just take Canis flor or some sort of vaginal probiotic before you start a treatment cycle. So yeah, it's a big area of development. I expect we'll see more studies in this area coming out. Tommy's have linked that initial thing, but I think we'll see more research in that area. Reproductive immunology, I am only going to scratch on this because I could do a whole webinar on this, and in fact I did a whole podcast on it, but yeah, this is basically when your body doesn't accept the embryo. So when we looked at that fertility pinch point, it was the last diagram where I was talking about the last circle, talking about is your body recognizing the baby or the embryo as self, and it's not attacking it and causing a miscarriage. Now that just doesn't cause miscarriage, it causes unsuccessful IVF and it causes natural infertility. So in my patients in the clinic who have never, ever, ever had a positive pregnancy test in like 2-3 years, we can't get to the bottom of what's going on. We've checked all the really obvious stuff. We've looked at what symptoms they've got going on and what might be the most likely cause for them. If nothing comes up, I go to reproductive immunology. Like, is your body so overactive that it won't even let an embryo start to implant? It definitely happens. All treatable, but this is private testing only. You won't get that tested on the NHS. There is a lady called Professor Quimby. Some of you might have heard of her. She's based up in Coventry, I think, or Warwick maybe. And she does this to some degree on the NHS, but not to the same degree that you'll get done privately. And then thrombophilias. This is essentially a blood clotting disorder. It's actually rare. It's quite rare to have a true blood clotting disorder. It's often hereditary, often comes with symptoms. Yeah, it's not that common. Occasionally it'll come up in the clinic, all treatable normally with Clexane or heparin. But yeah, it's often part of a recurrent miscarriage panel. They'll look at your blood clotting. But yeah, true blood clotting issue is quite rare. And then like genetic or chromosomal issues, and that boils down to egg or sperm quality. So, you know, is there something genetic going on, or have you got a diagnosed genetic condition? Now, most people would know about things like that from family history or their own health scenario. But sometimes, you know, it can just be egg or sperm quality. Now, again, I could do a whole nother webinar about that. And in our Facebook group, actually, Rebecca, my colleague's done like a preconception care sort of webinar where we talk a lot about things you can do to improve egg and sperm quality. And we're talking about supplements, you know, lifestyle, nutrition, all those things in the 3 months before you conceive or start IVF. So yeah, sadly, like resources on the NHS don't stretch to all of these things. Like I said, thyroid, sometimes they'll do a little bit, certainly vaginal microbiome, reproductive immunology, they won't do. Thrombophilias, again, they'll really only do after you've had 3 miscarriages. And then genetic, they do test for genetic things, but again, it tends to be, you know, if you've got a family history or diagnosis of something. So all these areas are areas that, you know, could explain your unexplained infertility. But I can guarantee that if you've been under the fertility clinic care, whether that's privately or NHS, you know, perhaps they're not talking about vaginal microbiome, or perhaps they're not looking at these things in enough depth. And these are all things that you can go about yourself. Again, I'll talk about that at the end. But yeah. And then this is something I just wanted to touch on, because I have so many women that message me either on socials or get emails saying, I can't get pregnant because I've got low AMH, or I've been told I'm infertile because I've got low AMH. Like, that is not a diagnosis. So AMH is a hormone that gives us a very rough idea about your egg reserve. As long as you are having a regular cycle and all the other things around that cycle are right, so your progesterone levels are right, you know, your uterus environment is right, the rest of your hormones are balanced, the male side of things is good, you know, your tubes aren't blocked, like low AMH is not going to stop you getting pregnant naturally. It will mean that if you have IVF, you will struggle to produce more follicles in an IVF cycle, but it's not going to stop you getting pregnant naturally. I have women in the clinic who conceive regularly with AMHs of sort of under 2, under 1 even. We know that your AMH will naturally decline with age, but it does fluctuate. It's a hormone, so it will go up and down. It doesn't tell you anything about egg quality. And like I said, it doesn't tell you anything about all the other things that are key for fertility. Yeah, I mean, the reference ranges can, sorry, this is a separate thing. So quite often we're being told everything is normal according to reference ranges. And those reference ranges vary massively from clinic to clinic, NHS to private. So if you're being told, no, everything's come back normal on your tests, get a copy of those test results and start asking around for advice, you know, and again, I'll talk more about this at the end, but yeah, like start asking people, like, is this normal? Do a little bit of Googling, like Google, we give Google a bad rap. You can actually learn quite a lot. You can go down a rabbit warren, but you can get a lot of information because reference ranges vary a lot depending on who's designed them and who's talking about them. And the final myth is that fertility falls off a cliff. Doesn't quite work like that. It naturally declines with age. Generally, most clinics will tell you that 42 is kind of like the not cut off, because again, if you're still having a regular cycle and everything else is right, then you still have a chance at conceiving naturally. But generally 42 is where things start to decline more rapidly in terms of egg quality. But again, it doesn't mean that you can't conceive. It just means you need to be thinking about egg quality a little bit more on supplements and lifestyle and things like that. Okay, so this is where we're going to talk about what you do about all those things. I've talked a lot about, you know, all these things that might be wrong, but the important thing is that we sort of help you to know how you can change that and what you can do and where you can go to get advice. So ultimately, you want to kind of get a diagnosis, or you want to know, going all the way back to the fertility pinch points, you want to know which areas are causing you a problem, because if you know which areas are causing an issue, then you can help treat it. So how do we do that? We do a little bit more digging. So hormone testing you can have done via your GP, and you're all entitled to get your hormones checked. You want to get them checked at the beginning of your cycle while you're on your period, and then you want to get your progesterone checked in the second part of your cycle, about 6 or 7 days after you ovulate. You can also use MediChecks, which is the finger prick testing service. They're brilliant. They're very cost effective. You can't be afraid of blood. So if you're a bit squeamish, probably best to go to the GP. But they do offer a nurse testing service where a nurse can come to your home and draw the blood for you. It's a little bit more expensive, but yeah, it's worth doing. They can pretty much check everything. They've got an extensive range of blood tests. So when we talk again about that beginning part of the cycle here, getting your hormones checked, and then this part here as well, like your lining, get your progesterone checked. You know, if you're not ovulating here, you're not going to have enough progesterone, you're not going to have an egg to fertilize. Getting your progesterone checked tells you a lot about whether you're having a normal ovulatory cycle. Sonography. So where we talked about all of these like uterus abnormalities and these undiagnosed conditions, this is where like good sonography is key. So the NHS often only use 2D ultrasound, and private clinics will often use 3D ultrasound. And there's a big difference between what you can see and what you can diagnose. A good sonographer that specialises in women's health is worth their weight in gold. So saline sonography, which is where we talked about, they put the saline in and blow up the uterus. Like previously, before we would put camera in, now we can use saline. It's much more gentle, much more tolerable for the patient. You can diagnose a lot, and then if necessary, a hysteroscopy, which is the camera. So for sonography, I recommend a chap called Bill Smith, who runs a company called Clinical Diagnostic Services. I'm actually just going to pop that in the chat because it's a great company. And Bill is like one of the best sonographers around. He's based in London, but he specializes in women's health and fertility and recurrent miscarriage. And if there's something there, Bill will find it. And he will do you an extensive report about what's going on. So again, like really looking at that uterus environment and making sure there's nothing there that could be stopping embryo development or implantation. If necessary, a laparoscopy, and this is how we diagnose endometriosis. And this goes back to what I was talking about when I said, like, we need to assess, is it actually affecting your fertility? So a laparoscopy is keyhole surgery where they go in, they diagnose endometriosis, and they remove it at the same time. It's quite invasive and it comes with risks. There's scar tissue that can build afterwards. If you do have endo, and it is affecting your fertility, like if you're not having a positive pregnancy test at all, ever, and you're really struggling with like heavy, painful periods, or spotting before your periods, then it might be worth considering a laparoscopy. It definitely wouldn't be my first port of call because it is invasive and it does come with risks. But again, it's about looking at your individual clinical picture and working out, would that be worth doing for you? But yeah, ultimately it can improve your fertility in the short term if they take the endometriosis out. I have had a lot of clients who say to me after they've had a laparoscopy and been diagnosed, say to me, I knew something was wrong, I knew something was not right, I knew it's not normal to have heavy, painful periods. Or they just had a gut feeling that something was not right. And in their cases, a lot of them do go on to conceive naturally after having the laparoscopy and any endo removed. But it's a bit of a risk because you could have a laparoscopy and there's no endo there. It shouldn't be taken lightly, and it needs to come with, the right advice and guidance. And then working with a nutritionist, a functional medicine practitioner, or a fertility expert like any of the women in my clinic, to understand how gut function and nutrition affect inflammation, egg quality, and hormone-driven conditions such as endo, adeno, or polycystic ovaries. So a lot of good fertility clinics now are open to discussion about the difference they see in patients that have worked on nutrition and gut function and reducing inflammation before starting an IVF cycle, or patients that have had repeated unsuccessful cycles, gone on to invest money and time in these areas, and then seen a big increase in either embryo numbers or improvement in quality, or just had a successful healthy pregnancy. So that, again, evidence is starting to come out now about how all these things can help. If you are really struggling to conceive naturally, or you're about to start IVF, I would always recommend, working with some sort of expert, whether that is a nutritionist, functional medicine, acupuncture, dietitian, anyone who has some sort of knowledge about how to reduce inflammation in the body and help you with supplements, that sort of thing. It's definitely worth investing in, for sure. Other things that we looked at, I'm just going back a little bit. So vaginal microbiome test you can have done through in vivo, but you need to have that through a practitioner. It's not a test you can just go and have yourself. So for any of the clients working with us, we're able to do that. So there's lots of acupuncturists, nutritionists, functional medicine practitioners who all have access to the in vivo microbiome test. So if you're already working with someone like that and you think you might want to have that test done, ask them if they can arrange the test for you. Something we do quite a lot nowadays in our clinic, actually. So yeah, but it's a company called In Vivo. You can go and have a look at their website, but you can't order the test yourself. It has to be through a practitioner. Thyroid function is something you can do through Medichecks and your GP and a fertility consultant. But yeah, you can certainly get that checked yourself. Reproductive immunology, you need a reproductive immunologist. So there's a couple around. You've got the well-known one, Dr. Shahata, or you've got Dr. Tum at the Lister, or Dr. Gorgie or Gorgie, I'm not quite sure how you pronounce his name. There's some sort of well-known reproductive immunologists. You need to go to them for the testing. This area is very complex, expensive, and you need someone who knows what they're doing if you've got an immunology issue. If you suspect you've got an immunology issue, they would be my 3 people to start with. Go and visit them, have a consultation, have the test done. But yeah, they will give you an effective treatment plan. Thrombophilias can be checked on the NHS. Most NHS, you probably have to be referred to a fertility department or the recurrent miscarriage clinic, but they can certainly check those for you. Genetic and chromosomal testing, things like karyotyping, that's a lot more specialist. And again, it's not something they do sometimes do it on the NHS, but again, you can get that done privately as well. But you need to be under the care of a private consultant. So there's lots of places you can start. What I would say is, if you get a second opinion, it's always worth staying in the NHS system, but get a second opinion. So I'll come back to these bits at the top, but I'm talking here about invest in private care if possible, but stay in the NHS. So you might be under the NHS care already. You might not be 100% happy. It's worth spending the money to invest in a one-off consultation with a fertility expert, like a fertility consultant. And Kate, you're with Dr. Dimitri. He would be my go-to. He's brilliant. He runs a company called Artemis Gynecology. I'll pop that in the chat as well. Go and see them. It probably cost you 250 quid. But what you get from that consultation, if you're struggling with the NHS, could be massively helpful, and it might change the direction of what you're looking at doing. And it's perfectly feasible to have private care alongside NHS care. You have to act as the go-between in between, but you can run the two alongside each other. So you could use the NHS for your IVF, but you could be having some private care if you have something diagnosed that the NHS can't help you with alongside that. And yeah, Kate's you're quite right, Kate. He does free 20-minute appointments. So yeah, he's brilliant. So yeah, you don't always have to pay, which is worth knowing. There's loads of people out there that want to help you, that are impartial and aren't after your money all the time, for sure. So don't always feel like you can't get the help. And yeah, Kate, she said, my GP wouldn't help, but he was great. Again, classic example. I often find with GPs, I don't think they're unhelpful because they want to be unhelpful. I think with fertility, a lot of it is to do with confidence. Like, they will happily refer you to a fertility department, but they don't want to get involved themselves. And it's like, I think that comes down to do with their confidence in their own ability to deal with fertility. You know, it's a very complex area, and nowadays there's a lot of patients going to GPs with fertility issues. Infertility is sadly on the increase. And you know, I think, you know, GPs, the first is like, I'll just refer. And actually things like progesterone, they can prescribe, and it saves a lot of time and effort of you having to go through the process of waiting for referrals, waiting for appointments, you know, to get something that could have quite easily been prescribed. So yeah, Dr. Dimitri for progesterone, or just even to get that free 20-minute call, he's brilliant. A lot of other great clinics. You've got ARIA, ARIA, which is actually where Dimitri's based, but he runs his own separate clinic. You've got the Eve Well. There's some really good clinics out there. Concept in like Wimbledon, Putney Way. The sort of way clinics are being run is starting to change for the good. So yeah, always get a second opinion. Always stay in the NHS system. If you don't want that appointment, you can cancel it the day before. They've got a waiting list. You know, don't feel guilty. Take both if you can. So yeah, going back to the top here. So yeah, shout the loudest. Like, no one wants to be the person that kicks off. No one wants to be the person that like sticks their head above the parapet and that wants to be the one that you imagine when you ring, they're like, oh, it's her again. It's her, you know. But sadly, like, certainly under NHS care, you have to be like, you are only going to get the help you need if you shout the loudest. Like, if you feel like, at the bottom I've got here, trust your gut. Like, if you feel like something in your gut is not right, then you've got to push for it. You've got to be your own advocate. You've got to get on the phone. Like, it's exhausting. I actually remember throwing a telephone at the wall one day because I couldn't get through to the person I wanted to speak to about something to do with my IVF. You know, it's draining. But you have to dig deep and be the one that shouts the loudest, because then you get what you need. Seek advice from an expert who takes an impartial view without vested interest. So yeah, I think this goes back to what I was talking about having whenever you take advice from someone, certainly in the realms of fertility, ask yourself what they stand to gain from that advice. For example, if you are going to a fertility clinic, they can't tell you why you can't conceive naturally, and they're saying to you, just start IVF, we'll get you pregnant. Like, and then that IVF doesn't work, and then you have another round and they're saying, well, we'll just try again. Like, why? You have to question what it's not necessarily in their benefit for you to succeed. And I hate to say that, but you know, it's not, it's a business at the end of the day. Like, you have to be aware that, I'm not saying all clinics are like this, but there is definitely, this does happen. So you have to be aware when you're taking advice, what they stand to gain from it. Allow yourself 3 months time. So 3 months to prep for conception, whether that's IVF or naturally, because we talked at the beginning about that, going back here to this fertility pinch point, about this 3 months prior, about what your hormones do. So take that time. And like I said, clinics are now starting to see a difference in success rates in people that take that time. But also, if you've got unexplained infertility and you want to work out what's going on to improve your chance of success naturally and at IVF, then give yourself 3 months to do this information gathering exercise. So go back to this fertility pinch point and look at everything that we've discussed and start ticking things off. Start looking at these things that we've gone through, start looking at the tests, but give yourself 3 months to do that, because that's how long it's going to take to go for tests, get the results back, arrange appointments, address anything that needs addressing that comes up from that, and get yourself in a better position. If you do those things, you may conceive naturally. It might be that you end up having IVF, but you've massively improved your chance of IVF because you know what was going on, you've addressed it, and you've optimized your chance of success. Get second opinions generally. Talked a lot about NHS versus private, but if you're not happy with your consultant, or you feel like you're not getting that like connection, or you're not being heard, go and get a second opinion. Like, and also, if you do get a diagnosis for anything, find a consultant that specializes in that. People always ask me, oh, can you recommend a clinic, or can you recommend a consultant? And my answer to that is always, well, what do you need them for? Fertility is a massive area. Like, do you need them for endometriosis? Do you need have you got polycystic ovary syndrome? Is there male factor issues going on? What area do you need help with? Because lots of clinics specialize, and lots of consultants like me, they have their own area of like passion, and that's where they've invested their training and their time. So therefore, if you go to a consultant that specializes in the area that you need help with, then you're going to get better care, and you're going to feel better looked after, and ultimately you're going to improve your chance of success, because they've probably done more research in that area than anyone else, and they probably have more clients coming through the door that are similar to you, and therefore they have a better understanding of the condition and how to treat it. Just because you start treatment with one consultant, it doesn't mean you have to continue treatment with the same consultant. Even if I have patients who have unsuccessful cycles with clinics but have like embryos frozen, we then get the embryos moved to a better clinic, or a clinic that addresses that's really unfair to say better clinic, I shouldn't have said that, like a clinic that better suits their clinical needs. It's not difficult to move embryos. Like, don't feel like you're tied to one particular clinic. If you're not happy and you're not getting the answers you need to improve your chance of success, go elsewhere, 100%. And just be honest with yourself. Say, am I getting the service that I should do? Especially if you're paying privately, you're paying for a service, so you should get the service that you need. Focus on the bigger picture. Don't get too restrictive. So again, something that comes up often is people saying, well, I've not eaten dairy for 4 months and nothing's changed, and I think like it's really easy to be restrictive with fertility, because you go online and you are told you need to do this, you need to do that, this is going to help, and you hear lots of different stories, and you read lots of different case studies, and so this worked for them, and so that worked for them. Like, it's really easy to lose sight of the bigger picture. And by bigger picture, I keep going back to this diagram, but it's so helpful. Like, bigger picture, like if there is something wrong with the sperm, you could eliminate all the foods and the joy from your life possible, but it's not going to help. If you are, if you're not ovulating, there's certain things that are going to help more. There's certain supplements and certain lifestyle advice that is going to help more than other things. It's about like knowing where the issue is. So first of all, finding out where the issue is, understanding how to treat that, and then doing the right things for you, because that can be different for everyone. For example, in someone who has Hashimoto's, like myself, sometimes going on like a gluten-free diet can be really helpful, because there's a link between celiac disease and Hashimoto's. For someone else, going gluten-free can be completely irrelevant, but yet they're being really restrictive in their life and missing out on things that they enjoy because they've read somewhere that not eating gluten helps your fertility. Like, don't get too restrictive unless you know that something is really right for you. And again, that's like looking at getting a diagnosis and finding the right experts to help you. I think as well, I think people always say, well, I've eaten this, and I'm like, don't want, like, having a glass of wine on a Saturday night and really enjoying it does more wonders for your relaxation than not drinking at all for 4 or 5 months. Like, I'm not saying you should be drinking every night of the week or getting smashed every Saturday night, but one glass of wine on a Saturday night, make it a nice one and enjoy it. Because as we said, is that one glass of wine going to stop ovulation? Is it going to mess up all of your hormones? Is it going to stop the embryo from implanting? No, is the simple answer to that. All these other things we've discussed will, but a glass of wine on a Saturday night won't. So yeah, just don't get too restrictive with it. And then finally, if you are considering IVF, or you're at the point where you want to have IVF, go and visit clinics. Lots of them do open days now. Lots of them, like Dimitri, do the free phone calls. Try and step away from the statistics a little bit, because these are easily manipulated, and often they're all very similar, actually, when you look at it. Think about the things that really matter. Are they approachable? Are they open? How close are they to you? Are you prepared to travel or not? Are you at the right clinic for you? I.e., do they specialize in the area you need help with? Again, all these things can really help optimize your chance of success. I think if you have unexplained infertility and you want to go for IVF, when you go to the clinic, the best thing you can do is ask them to help you understand why you're not conceiving naturally before you start IVF. And most of them will probably be really surprised that you've asked that, but actually it's logical. And I know this is how Dimitri works. You know, he will look at the reasons why you might not be conceiving naturally before, you know, generally he would take 3 months. If someone rung him and said, I want to start IVF tomorrow, he wouldn't see you. He would want you to take 3 months to invest the time and the effort into understanding what's going on, what you can do to optimize the chance of success. And that's really what you want. You want someone who just takes a bit of time to invest in you. If you walk in the door and they're pushing IVF on you, they want you to sign up for 2 cycles, you know, I'd be running in the other direction, for sure. And trust your gut, finally. I've said that a few times, but yeah, just really trust your gut. Nearly all of my patients who struggle with unexplained infertility and go on to have a diagnosis of some sort, or have a diagnosis, have successful IVF treatment, will go on to say to me, I knew something was not right. You know, I knew all along, like something was telling me that, you know, XYZ was the problem. So if you feel like something's not right, going back to here, shout the loudest, like be the person that, you know, draws a bit of attention and gets the help they need. So yeah, so that kind of wraps up my chat. Give me a few minutes just to finish off, and then I'm going to go to the chat and see if anyone's got any other questions. But basically, if you feel like you want more support, then we offer all of these services. Probably the one that's most helpful for unexplained infertility is our online fertility consultations. So we offer a 90-minute call where we go really in depth and we go through all of these things I've talked about, and I'm going to ask you 1,000,001 questions about your menstrual cycle, your vaginal health, your partner's health. You're looking at any test results you've had already. I'm going to go through them with a fine-tooth comb and really look at what's been checked, what's not been checked, and then essentially we create an action plan for you. And that action plan might be like, okay, I want you to go and have a 3D ultrasound, or I want you to go and get your thyroid antibodies checked, or I want you to go and see this consultant because they could really help you. Like, yeah, basically it's a unique tailored action plan. And then we look at supplements, lifestyle, nutrition, all those sorts of things. And we create a plan for you that's unique to you and your scenario. And then you get that emailed over to you at the end. So yeah, if you think there's something that can help you, you can book that on our website, which I'll pop in the chat. But I'm just going to go back. I'm going to stop screen sharing now. I'm going to go back to the chat, and then I'm just going to give you a chance to ask any questions that you might have. And I've put the clinic website up there. So yeah, hopefully Corinne, you didn't get kicked out. I can still see you there. But yeah, if anyone's got any questions, now is your chance to ask. Otherwise, you can drop me an email at any point. I'm going to pop the email address in here as well, because sometimes it's like information overload, and I have just given you a lot of information. So if you want to email, you can pop me an email at any point. But yeah, anyone got any questions? Or if you want to, feel free to take yourself off mute and then ask away. And obviously, because there's not many of you live, I'm happy to try and help with any sort of personal bits and bobs if you're happy to ask in front of everyone. No? Okay. I'm going to leave it there then. Oh, hang on, Kate. We're not quite there yet with the clinic. Waiting on NHS referral. If, for example, you have a cycle, how easy it's changed if not happy. So the NHS have this thing called, I think it's called NHS Choices now. So when you basically, once you've applied for your funding for NHS IVF, I think you're then sort of under that care. At the beginning, but i.e. before you start a cycle, you should get an NHS Choices options. So there's normally like 3 or 4 options of clinics closest to you that you can choose. I'm not sure where you are, Kate, but yeah, like for example, around here it would be Croydon, Kingston, and maybe somewhere in Kent, maybe. So they give you a choice. I'm not sure if once you've had a cycle, how easy it is to change, because it's to do with the funding. So you might have to reapply for funding again. it depends how many cycles you were entitled to under that primary care trust. If you were only entitled to one cycle, that cycle didn't work, and you then want to change, effectively you should be able to reapply for funding under a different primary care trust. But if you've got funding for 2 cycles under one primary care trust, they might want you to have the 2 cycles under that care trust, if that makes sense. Colin, would a gap in a period, e.g. 3 days of bleeding, then a day of clear discharge, then another day or 2 of bleeding, suggest that any particular tests be done? I've had 3 miscarriages. Okay. I'm sorry to hear that, Colin. 3 miscarriages. That's tough. I've, been through similar myself, so I do understand. I'm assuming that you've been referred to the NHS recurrent miscarriage clinic. You should have done, if not. Any tests that I would recommend? Yeah, absolutely. So there's all of the things we've talked about can cause miscarriage. I would start with saline sonography scan, where we have a look at the uterus environment, because that is a common cause of miscarriage. That's something going on with your uterus. So a saline scan with Bill at Clinical Diagnostic Services, who I recommend, and you can just book that direct with him. And then I would be looking at probably a progesterone blood test in a natural cycle, just to see if progesterone would help. If you have any spotting before your period, that would be a classic sign that progesterone might help. I don't think the gap in a period is that significant, to be honest. If that's always the case, then it could be a sign that maybe there's something lining issue going on. But again, having that saline sonography would it sort of check for things like that. I would definitely have a thrombophilia profile as well, so like that blood clotting, and a thyroid panel for sure. Thyroid is something that comes up all the time with miscarriage. It's just not checked often enough. So yeah, I'd go saline sonography, I'd go a thyroid test and thrombophilia tests, and progesterone as well, to check whether you've got good progesterone. But yeah, drop me an email, Corinne, if when you've got those things done you're still no clearer, because we can definitely help you with that. Hey, thanks. Yeah, if you want to move to private, you can go private anytime, any point you can go private. You just need to find the right person. So yeah. Nikita, how can my partner improve his sperm morphology? So first of all, I would be looking at supplements. So it's really easy in men to over supplement. I would recommend just taking one supplement of something called Impril. I'm going to pop that here. Impril. A second. Impril. I've just realised, sorry, when I've put the previous details down, for some reason, Kate, I've direct messaged them to you, so I'm just going to put them back in the group. Honestly, my technical skills, I'm naff, sorry. That's the Scan Man. Impril's the supplement. I'm going to come back, Nikita, to talk about that. Clinical Diagnostic Services is the Scan, Bill Guy. And then this is our website. And then this is my email. God, sorry, it's been a long day. What else do we put? And then Dr. Dimitri is Artemis Gynecology. Sorry, you wouldn't be able to see those before because for some reason I direct messaged them to Kate. But yeah, so Impril to improve sperm morphology, but Impril will only help if there's nothing else going on. So if morphology, so sperm reproduces every 72 days. So the first thing would be give it 72 days and do another sperm sample and see if anything's changed, because sperm is really sensitive to change. And quite often you see big changes after 72 days. So get it retested. If the morphology is still low, I would go and see a urologist. So a urologist is someone who specializes in sperm health and urology, basically, all to do with the testes and how sperm is produced. I would recommend Jonathan Ramsey or a guy called Suits Minhas. I'm going to put their details here, because they will check for things like sorry, I can't open. Here's a urologist as well. They will check for things like infection or varicocele. So a physical exam. So basically, they're going to feel your husband's testicles and feel for a varicocele. They're going to be doing a semen culture to look for infection, because all of those things can affect morphology. So you can take Impril and eat the best diet in the world and really look after yourself. But if there is a varicocele or infection, the morphology is not going to improve. So my advice would be take the Impril, retest after 72 days. If there's no improvement, go and see a urologist for sure. Okay, Corinne, no problems. Yeah, pop me an email, Corinne, if you've got any questions, if nothing was clear, if it's dropped out. You're welcome, Nikita. Yeah, okay. If there are no more questions, I am going to log off, but email anything to this email address. And then we will go from there. Yeah, it was lovely to see you all. I'm sorry about my poor technical skills at the beginning. But yeah, any questions, pop me an email and I will see you all very soon. Bye.